Hello and welcome to today's webinar, Power of Knowing, Advanced Care Planning, How to Share What Gives Your Life Meaning. Understanding comes from knowing, and advanced care planning is something that many have heard about, but few have done. This webinar will explain that advanced care planning is important for everyone, what it is, and especially important when we are well. Palliative care will also be explained and the role it has in helping those with serious illness make decisions and have difficult conversations to be sure that each person's wishes are followed for their care. The Power of Knowing is a free webinar series created by AuthoriCare Collective, a nonprofit organization that empowers people to be active participants in their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. To get us started, please welcome our moderator, Risa Hanow. Risa serves as clinical and community educator at AuthoriCare Collective and is also a member of the Cone Health Ethics Committee. She's a licensed clinical social worker. Risa, I turn it over to you.
Thank you, Paul. It is my pleasure to introduce our panelists for today, Dr. Elizabeth Golding. Dr. Golding is the Medical Director for Palliative Care Services at Cone Health. She is board certified in internal medicine and hospice and palliative medicine. Dr. Golding leads a vibrant and collaborative community of professionals who work at the front lines to improve care for our sickest and most complex patients. Dr. Golding has a special interest in clinical empathy, complex patient-provider communication, population health, and serious illness management. She mentors internal medicine residents and provides several highly interactive teaching sessions using role play and video performance feedback on how to have difficult conversations with patients and families. Dr. Golding currently serves on the North Carolina Institute of Medicine Serious Illness Task Force and is leading state and local initiatives to make patients' advance directive documents and preferences for treatment easily accessible across all healthcare settings. Dr. Golding, thank you for being with us, and you are the perfect panelist for our conversation today.
Thank you, Risa. It's a pleasure to be here and to get to have this experience and work with people in our community around this topic that's very special to me, not only personally, but professionally as well.
And we want to know a little bit about who's joining us. It's always helpful. So you can see on your Zoom screen, we have 3 questions today. They are, the first one is who is joining us? That's a multiple choice question. So you can check all that apply to you. The second question is, do you have a completed living will and or healthcare power of attorney? That's a yes or no question. And the panel, the polling is anonymous, so please feel comfortable to answer the question. And then if you answered yes, that you do have a document, we would love to know whether your medical provider has a copy of it. So if you could take a moment to answer those 3 questions, we will use some of that information as we begin our conversation today. It's always good. So we have many joining us today that are caregivers and advocates and healthcare professionals. We have many people, certainly, let's see, that have advanced directives and have a document, about 50-50, which is really more than what we see in the general population. But where we really want to talk about during our time together is the importance of sharing that information. So thank you for participating in those polling questions, because that's a perfect start for us, Dr. Golding, when we think about advanced care planning. So that's broader than the documents themselves. So can you talk to us about what the broader topic of advanced care planning is and where those documents fit into that?
Sure, Risa. So advanced care planning is a large topic and it can encompass a lot of different aspects of your care. Advanced care planning really refers to really your health care choices at any really stage in your life. And so, one of the things that when I think about advanced care planning, I think, it's not like always a one and done kind of thing. I think most people who engage in advanced care planning at certain points when they're just doing maybe their estate planning or their documents and it goes into a packet and it goes into the safe and nobody really thinks that much about it. You kind of put a person who would be the logical, person to be your healthcare power of attorney or decision maker at that time. And then things change over time. But advanced care planning it really encompasses really our lifespan. So from the time we're 18 years old and an adult, going to our first maybe appointment with an adult primary care provider, advanced care planning should really be discussed because in the event, if you're young and healthy, accidents happen. Sometimes people end up in the emergency room with, things unexpected. And if you're unable to speak for yourself, it is really important that healthcare professionals know who to contact and who they can share information with and speak to in the event that very important decisions need to be made. So healthy people do need to engage in advanced care planning. And as you progress through your lifespan, that needs to be revisited based on your circumstances. So when things change in your life, maybe you have a new relationship or you establish a marriage or you have a child, there's all kinds of points at which that should be reviewed. Maybe when you register for Medicare for the first time, or you get a new diagnosis of an illness that may progress. So certainly advanced care planning can really occur at any point along our life and care continuum. Advanced care planning, many people think of that as being things like a living will, thinking about your wishes should you become very sick and making sure those are kind of in writing and have some support behind them. But advanced care planning can also encompass really shared medical decision making with a healthcare provider that you have an encounter with that may be helping you through a serious illness. And at that point, you can address your documents, but there are multiple documents that you can actually use to convey your wishes. But the advanced care planning piece for most people at basic level will include the living will and documentation of the healthcare power of attorney. Those are the legally binding sort of documents. So those have a notary and two witnesses, and those can stand in the place for your decision making if you're unable to do that.
So
Yeah.
as we begin the conversation, I want to invite the participants certainly to make use of that Q&A box. So if you have a question that comes up during our conversation, please send it to us and we will try to answer it. So I want to talk about a couple of things you brought up. The first one was you said that anyone who's a legal adult and can make their own decisions should really think about doing this. And realistically, it's a hard conversation. It's, I don't know that unless something has occurred, unless maybe someone in our family has gone through an illness, or it seems like oftentimes there's something that makes people begin to think about this. But we want to put it front of mind as much as we can for everybody.
Yeah, there are lots of sort of cultural, societal, and very American sort of issues that go along with this. So we are in general a culture that doesn't like to think about death and dying. We're sort of a death denying culture. But it's bigger than that. I tell people it's not just how we think about it. Our brains are actually built to not think about dying. That's how we can get up in the morning. And we are actually wired to not think about our own mortality or to confront it on a regular basis. So it actually takes conscious work for us to think about like the fact that we're going to die, every single one of us. And so it's an uncomfortable feeling for many people, and it takes a bit of energy. Now, when I say that, it doesn't mean that's a reason we shouldn't do it or can't do it, because on the flip side, that we are also a society that plans a lot. We plan for a birth plan. So if you're going to have a child, one of the things you give your, provider, is your birth plan. So, or you prepare for college. You may even save money for that. You prepare for your retirement, and you have retirement plans. We plan weddings, we have insurance for things that might happen in the future. So we do plan in our culture. And it is actually pretty important to Americans to do that. And we know that people plan for their death and what happens to them after they die. So people purchase where they're going to be buried. So many times patients and families will share with me what hymns will be sung at their funeral. But what we fail to do is plan for what I call the end of life care planning gap. So it is the period of time in our lives where we're actually stand to lose the most because we're the most vulnerable. So we may have a healthcare condition that's starting to deteriorate. We don't really know who's going to care for us or how we're going to be cared for, how we're going to pay for the care that we need. So we fail miserably as a society in that space. And it really causes a lot of suffering, not just for the patients themselves, but for the families.
Right. I often think about, it's a gift, because when you're talking about societal norms, the other thing is that we tend to be fairly independent. So I want what I want, but if I ever can't speak and tell you as a physician what I want, what we are talking about today gives us that path for me to identify somebody who can speak in my voice. And I think it's important maybe to talk a little bit about when we engage in this healthcare planning and we consider who we might name as a healthcare power of attorney, to recognize they don't get to speak unless I'm unable,
Right.
but also how we pick who that person might be.
Yeah, and to also understand, if you don't make a choice, what the North Carolina laws basically say who will make it for you. Meaning, it could be a parent, it could be a spouse, and maybe a spouse that you're separated from, but you're not legally divorced from. It could be a sibling or the next of kin. There is a hierarchy outlined by the state in terms of who would make decisions for you if you do not designate that person. And so I really stress to patients who have, there's no normal families. Every family has their issues. But when there are sort of rifts or there's confusion about who and the what's, and, you need to designate who that person should be. So I always say, when you're choosing a healthcare power of attorney, it doesn't have to be always who people think it should be. I have many situations, even when patients have not selected their spouse to make those decisions because they feel like it would just be too hard on them, even though they've had conversations about it. Sometimes they'll choose people who have some medical knowledge that they trust. It really depends on the individual circumstances and situations about who someone will choose. The most important thing is whoever you choose should be someone who you trust, but also have a conversation with. That person needs to be aware that they're serving as your healthcare power of attorney, and they need to have a copy of the document that you complete to certify that. So those are the most important things about that decision. The rest really is so personal and very much about being able to talk about what your preferences might be. The other thing we have trouble with is talking about what if scenarios. There is no way we can always, with 100% certainty, predict what's going to happen to us or how things would progress to the point where somebody needed to speak for you. And so what I tell people is to really talk about generalities. Sometimes maybe there's situations that occur with somebody that you know who gets sick, or a church member, or somebody, a friend. Those kinds of things are good starting points to say, if I were ever in that situation, here's what I would want.
Mhm.
So there are lots of sort of ends to the conversation, and we need to recognize those, and that's an important takeaway for the people on this call. When you have that end to have the conversation, it's the right time to do it.
Right. So everybody who's on this call can go to their loved ones and say, I watched this webinar. I want to have a conversation. I know that sometimes people who are younger, healthy, they have perhaps a fear or a concern that if they complete a living will, that if they were to have an accident or have an acute event, that they would not receive emergency care, or they wouldn't get really life-saving care. And I know that the understanding of what a living will actually covers is something that we should probably talk about.
Yeah. The language set forth in a living will, which is the part of the advanced care planning, that discusses some very specific scenarios. The living will was really designed for patients who may be in a situation that was something like a persistent vegetative state, or in a situation in which they have an absolutely irreversible condition that renders them with a high amount of certainty to not recover. So neurodegenerative diseases, progressive situations, advanced dementias, and unrepairable, unreversible brain damage. So in these situations are also very specifically outlined, at least in the North Carolina State Form for a Living Will. And there is also language that says, if your physician or provider, deems, these situations to be occurring, that's when this applies. So your living will should never, under any circumstances, dictate any medical treatment outside of those states. And again, those are very severe states, being in a persistent vegetative situation, or being irreparably brain damaged. So that's important to know. They will not impact your interventions or treatment otherwise.
Right. And I think that's helpful because sometimes people view the document as something that may limit their care or limit their choices, when really these documents are almost that insurance plan that what gives my life meaning will be followed even if I can't speak for myself. And which leads me to the conversation of, just because I have a healthcare power of attorney doesn't mean that person can make decisions for me if I can make them for myself, correct?
That's right. So, none of this means, these documents have no power unless you're in that state. So if you are a patient, or, who is speaking for themselves and has the ability to do that with a reasonable degree of capacity to do that, your healthcare team will work directly with you and your designated people in your presence. There is really no power to these documents if you're in that state. These are truly designed to be used when you cannot do those things. And so I always tell people too, the things you choose in your living will are important, but the most important thing is who speaks for you. And the forms do allow you to select whether that person can sort of change any of your choices, or they are to follow directions exactly as you state them. And so that's another important thing. It's also important for people to know on this call that whoever is acting as your legal healthcare power of attorney will be treated as if they are you. So in other words, any decision that they make when you are unable will be the decisions that the healthcare team will follow.
And for the healthcare power of attorney, we never want to put somebody down unless we've had that conversation. And we can list a primary person, and then we have the ability to list a second person if that first person, our primary person, isn't available. So the same level of thoughtfulness is necessary there.
Yeah, I think that's truly important. And that the person who you select is willing to do this. Sometimes we have very complicated situations in which the people who are selected, when it comes down to, are not the one, they actually do not want the responsibility of making those decisions when they occur. And those can be very challenging situations. And when they happen, I always say there wasn't enough conversation that was had, and so again, it is a thoughtful process and should be.
And I'm also thinking about families or friend groups or faith community members. We can involve a lot of people in these conversations along with our healthcare providers. Naming somebody as our healthcare power of attorney doesn't mean that others can't be included and important in our care. It just means that somebody has taken on that responsibility of speaking in my voice if I can't, but those around us can be a part of that conversation because for some people, it's very faith-based. For other people, it's family tradition. For other, there are different things that give our lives meaning, and we want to have conversation with as many people to help us really get our thoughts shared so that everybody has a sense.
It's very validating in a crisis too. So, when I sit down with families in the waiting room outside the ICU or the ER, those are some of the more intense encounters I have as a physician. And it is always painful when somebody has gone through the process of even having a healthcare power of attorney and that person understands their role and is willing to step up, and then they are questioned by other members of the family. And so it is always a good idea, to the degree that someone is comfortable, to have that conversation with more than just that person, but to make your wishes sort of known, at least in general terms, to people who are important to you, who may be around at the time that this may be pertinent to the situation. So, I think to the degree we can include our families and the people around you, loved ones, friends, those people are important to this decision, regardless of whether they are your designated healthcare power of attorney or not. There are also people who are very private. There are people who truly want these types of things to be held in close confidence. And in those situations, I think it's important to let your provider know that, and also to let, that healthcare power of attorney understand that too, and what your wishes may be around who and what is involved in your decision-making process.
So I know you said that this is not a one and done conversation, but we are at the place where I'm going to have conversations, and we'll talk about how we start that conversation, but I'm going to do a document. I'm going to complete a living will, a healthcare power of attorney. And as you mentioned, it needs to be signed in front of 2 witnesses and a notary. But what do I do with it then? Because I've done this work to have conversation, but what happens next?
Risa, that is a great question. And I do believe one of the most important things that we should consider here today. So, like I said, many people may even have these documents. So one is they need to be reviewed and updated. If you even have one now that you've got to blow the dust off of, it's probably time to review it and make sure it's still, what you want. But the main thing is that document needs to be accessible. It needs to be visible. It needs to be findable. And the best way to do that is to first share it with your healthcare provider. We are fortunate here at Cone Health to have an advanced care planning platform built in within our electronic medical record system that will scan in those actual documents so they're available at the point of care. You can also access those documents through your web portal, through your MyChart or your web portal, And your primary care providers or close providers should be able to assist you with that anywhere in the Cone system. But we are very fortunate to have that tool available. This platform also updates the records and keeps track of any changes that are made. So the single most important thing you can do with that document is to share it with a trusted healthcare provider and the system that you receive your care in. Otherwise, the document's still the original and hard copies of that document need to be given to your healthcare power of attorneys or attorney, and also need to be in an accessible place within your home. So the important folder, I know my own mother who's 85 has that important folder. And so everything that I may need upon her death is right there, for me to see, or even before that. So those documents that could be very vital to how she's cared for also are in the important folder. So
I often think about giving it to people that are named and also people who aren't named, right? So that can be a way of having a conversation with some of those people that are close to us, but might not be named as that decision maker. And so let's talk a little bit about how we start the conversation. So I know if I say to a loved one, I want to talk to you about living wills and healthcare power of attorney, I might get a response of, oh my gosh, did something just happen? Did you just go to the doctor? And sometimes, yes, it is a diagnosis that starts the conversation. Sometimes it's coming to this webinar, but how do we start them?
So I'd like to think eventually we'll evolve culturally and from a societal standpoint that this conversation is not just something nice to have, but it's expected and it's normalized at many points in our life. It's just part of your regular healthcare and life stuff. So check, I've got my advanced care plan, check, I'm up to date on my screenings, check, I've got my, health insurance is in place, my car insurance is in place, my advance directive is in place. To really normalize it as part of just what we do as humans, because that's the way we take care of ourselves and our loved ones. It's expected and normalized. We're not there yet, but, I think in this context, starting the conversation, in my experience, usually happens when it has to happen. And I'd like to see it done at an earlier point. But if it has to happen, when you have a diagnosis that could be potentially serious, life-threatening, maybe even, even a terminal diagnosis, you have to talk about it, because if you don't, the failure to do that could potentially lead to undesirable situation for you as an individual. Medical technology can do lots of really wonderful things, but there are some people who may not feel like they benefit from that when their suffering is prolonged, or they have very intense prolonged stays where they may even be on life support. So if you're going to have this conversation in a crisis point, I think you have to use the crisis as a way to bring your family together and say, this is important to me. And I know this is hard for you all to hear. But we need to talk about some serious things now. And so you can have that really serious conversation that gets everybody's attention. But outside of that, I think the normalization part needs to happen in the least likely places. At the dinner table, at Thanksgiving, to bring it up and say, great, everybody's here together. So I want to make sure everybody's clear on this. And then to begin that sort of conversation. Some people may excuse themselves from the table, but that's okay too. They will eventually know that it's important to you, and they'll come around and listen. And I always say, for the wise, elders and families, how you confront this really, it translates to the rest of your family and the generations who will come next about how they deal with these things. So if you are courageous and brave about talking about these things and being clear about the things that you would and would not want, you're teaching your children, your grandchildren, how to confront the inevitable part of living, which is that we will die. And everything is living up until that point, including the decisions that are being made in your advanced care plan. It's all living. Death is really just that moment and everything up. So you're really making a life plan. It is about how you live in that period of time, where these documents may be very important to how that occurs.
And I love how you put that, and it makes me think about once we make these documents, we know that something could occur that would have us update them or change them. I've heard, when we change our clocks, we should check our smoke detectors. It would be lovely if we had an automatic reminder to pull that document out and make sure that the person that we have named or what we have put in our living will continues to be what we want. And realistically, I think it probably happens if I do receive a diagnosis. I've been told I have Parkinson's or I have a cancer that has spread. I'm guessing that is a trigger for many people who have a document to pull it out and look at it, because then we have to have another conversation, right? Because we're in a different place.
Well, and I will say at Cone Health, we have really, as a health system, really thought about this. Patients need to know why we're asking. And now it used to be sort of like we would just ask, do you have an advanced care plan? Yes, no. Do you want information on it? Yes, no. And then just stop there, right? But people who access our system really may be getting more information on this. And the reason why is because we feel like it is a cornerstone of how someone is treated when they come here. Like, it's a basic thing for us to know who we should talk to if you're unable to speak for yourself, and that you have had conversation with this person, or to know what your wishes would be if things are really serious for you. And advanced care planning for someone who already has serious illness can look a little bit differently. There are ways that you can specify your goals of care and your choices for care outside of the living will document. So when we talk about advanced care planning changing over time, I think as people experience healthcare, we are going to be asking about this. We are going to be talking more about your goals of care, because they are just that important, and they really determine, how you live in the face of whatever illness you may be confronting.
So I know that it is the law that when you are admitted to a hospital or a hospice or a home health, that we are asked. But in addition to that is adding that conversation. And it's a positive thing that we are asked. I think sometimes people are possibly surprised and so knowing the why and the benefit for that conversation is helpful. It also makes me think about the need to, if I want to change my document and I make a new one, I need to then get that new one in the hands of everybody that I got the previous one. Correct?
That's right. Now, if it is scanned now in your medical record, that document will be, if it's in the Cone system, it will automatically be updated in your chart. So it will replace the old document. So we are fortunate to have that technology available. So your most recent document will be visible in the Cone system. But again, that doesn't substitute your communication about the changes to your loved ones who need to know, and to replace their copies with updated copies.
And I would imagine for anyone who might be utilizing a different health system, really asking to see if similar technology is available. And the other thing that comes to mind is we know that we have some people who maybe spend winter in one place and the summer in another location. And these documents are state specific. So we're referring to the North Carolina documents. Every state has their own documents, and we hope that a document would be followed. But I've always heard that best practice is that we want to have a document for where we are the resident. And if we live half a year in one state and then go somewhere else, that we can have documents for both states and make sure that they are matching and they are shared, but to be sure that we're using the state-specific form.
That's actually really important. There is reciprocity for most states. However, the recommendation is to have a state-specific form if you move or you live in two different states or spend time receiving care in a healthcare system that is in another state. And for bordering places, even for some of our service area, that can be important if some of your care is being, for example, provided in Virginia and some of it's being provided in North Carolina. But in general, there's reciprocity of those documents, and most states would honor another state's directive if they had that directive available. So getting a directive to any provider that you have and making sure it's accessible to them is very important.
And to get a document, so we will, after this webinar tomorrow, everyone who registered will get a email and we'll have a link where you can download documents. There are many resources. These documents are free of charge. They can be completed free of charge other than a notary if there's a fee for that. So it really is something that we want to think about reducing the barriers as much as possible, recognizing that we do need those two witnesses that aren't family members, and then we need that notary. And there are different people within different healthcare systems, within AtharaCare Collective, different community organizations that can be good resources for people.
Definitely.
So I want to think a little bit about, we've mentioned why everyone who's healthy and should have a document, because that's our insurance policy. But as you said, lots of times it's when a diagnosis has been given, and that's when we might think about palliative care entering. And so maybe start us with explaining what palliative care is and
Sure.
who it's for.
Yeah, I'm happy to do that. So palliative care, while it often evokes a lot of fear and almost a trepidation by a lot of people, once they experience us in terms of what we're able to provide as palliative care providers, they often say, "Where have you been my entire, illness?" Because palliative care really takes care of patients who have serious illness, but the focus is on improving their quality of life that is supportive to the other care that they're receiving. It can occur regardless of where you are in the trajectory of your illness. It does not have any time limitations or prognostic regs. Anyone can receive palliative care who has a serious illness and needs a supportive provider or team to help make their journey easier, to ease their burden of suffering, and sometimes to really navigate a very complex healthcare system. Palliative care providers and palliative care teams are extremely advocacy oriented. So we take a very personalized approach to providing care, and we are solution oriented too. We want to figure out the best possible solution for you, whether that's treating your pain, maybe that it is making a hard decision about some treatment option that you've been offered, or maybe it is that you're having a really hard time getting your in-home care services, or you are having trouble with, making a care decision. There's all kinds of ways that palliative care can help support you, and not only just support you, but your loved ones, your family members, friends who are in your care circle. Sometimes illness can be equally as hard on them.
Right.
So it is about a relationship with that patient, and it's a healing, helping relationship. Sometimes I'll say, we know what's the matter with you, but what matters most to you. And so I always use that as my foundation for how I'm going to help that patient. because that determines how I treat their pain, their nausea, how I treat their shortness of breath, or any symptom they may be having. Because any treatment recommendations have to be considered within the context of their goals of care.
So if somebody is in the hospital, whether it's Cone Health or another system that has a palliative medicine team, I, as a patient, as a family member, can ask who for a palliative referral.
Yeah, it's not always it will not always be the logical referral that comes from your other providers. I always say sometimes we are a forgotten subspecialty. So you get specialists when you have really bad heart. So you get, referred to a cardiologist, or if you have really bad lungs, you get a pulmonology consult. But if you have overarching serious illness and a lot of challenges, the natural instinct isn't to refer you to palliative care. Often providers feel like if they mention palliative care to patients that they freak out or they lose hope or they think it's the end. When what our data actually shows is that when you have palliative care involved with the standard of care, you live longer with a higher quality of life than without it. And so that's important to consider.
Right. So we can advocate for it. And if we are not in the hospital, there are community-based palliative programs, both sometimes community-based, like at a cancer center or other environments, and then home or facility-based palliative programs like we have at a ThoraCare Collective. And so there's many options where people could ask about or receive that palliative care.
Yeah, and palliative care truly is, while is a relatively new subspecialty within, I'll say, medicine and healthcare, we are growing in how we offer services to people and in really helping the larger healthcare industry recognize and appreciate the value that's added. That comes from the patient experience and the provider experience with palliative care. And so as we serve more patients, it's important that we are, looking at this and expanding our services to meet the needs. I think what I hear most is that people want access to palliative care services, but often feel like they are not able to get those. And when they are able to get them, there are certain limitations on how that can help them. For anyone who's experienced that, we are growing and developing. And, ultimately our goal is to be able to have easily accessible palliative care for anyone in this community, whether they're at home, whether they are in transition, maybe they are in a skilled nursing facility for rehab, maybe they're in assisted living, or maybe they're in the hospital or just showed up in the ER. But we would like to ultimately create a service that can meet patients wherever they are in the continuum of not only just the healthcare industry, but their illness as well.
Right. And so we have a couple of questions and very much speak to our conversation. So somebody has asked that it's easy to decide that I don't want CPR or I don't want intubation or a feeding tube, but it's harder to think about whether I would want fluids. And I appreciate your thoughts, the person asked. And so it sounds like we know that some things we know very clearly. I wouldn't want CPR if my heart stopped. I wouldn't want to be on a breathing machine. I might know that I don't want food if it had to go through a tube. But fluids, I think these things are very personal. Sometimes they are faith-based. They are also, what happens if I don't get fluids? Am I going to suffer?
And that is why I think some of these conversations have to happen with a healthcare provider who can help put into context some of this information. What the question in the living will addresses is sustaining a person who is otherwise unresponsive and not who meets those qualifications with something like fluids, like IV fluids, because you cannot drink or eat for yourself. This is not as hard of an issue as I tell people, because here is the thing. If you have an irreversible neurological condition, you will not resume the ability to eat or drink fluids. I mean, either way. And so I really don't like the menu option, because I think it also asks us to make an impossible choice. And the choice is very clear. If you would not want to be sustained on life support, that life support includes nutrition and fluids. And then when people wonder, well, am I going to starve to death? Or am I going, the answer is simply no. You will pass of whatever your underlying medical condition is, not anything that we failed to provide for you. And so it's important to know that any choice that's made on these documents is not the choice that will lead to your death. It is merely an intervention during the end of your life when your death may be imminent, but is being prevented by life-sustaining technology.
And so if somebody does not have IV fluids and they are not taking anything in by mouth, that does not mean that they will suffer. There are people who die very peacefully in that situation.
Yeah, part of the natural dying process actually favors not having those things. As our bodies progress towards end of life, certain physiological things occur that I feel like when we interfere with those, we actually create suffering. So for example, if you provide fluids, to someone who has heart failure or someone who may have very low protein because of either malnutrition or because of their medical condition, you could potentially create a situation that makes it very hard for that person to breathe. It also could make it painful for them. Our bodies were actually designed to go and really release its own pain relieving endorphins in a dehydrated state. And also artificial nutrition can cause all kinds of very painful and unnecessary symptoms at the end of life. So for example, when we give tube feedings, generally we deal with things like diarrhea. We deal with like stomach getting very swollen with the tube feeding, which then makes it hard to breathe. It could even create a situation in which the patient vomits. So not always implying benefits. So just because we offer something does not imply benefit. And just because it's your choice does not imply benefit. So thereby not doing those things doesn't mean you're either A, choosing something that could help you,
right,
but we aren't providing it.
And I think that's where the conversation, the understanding, because I think I'm thirsty after standing here talking, but that's very different than the person we're speaking about and the condition that we're speaking about. There's another question about, I worry about developing dementia later in life. Are there options I can specify in my advance directive for my care, specifically if dementia emerges? And I know far progressed dementia is one of those triggers on the living will. We can put some comments, but do you have any particular advice or maybe thinking about other documents that are available?
Yeah, and Risa, and to the guest who asked that question, this is why the healthcare power of attorney is so important. I feel like I was saying earlier, we can't always predict the situations we're going to find ourselves in. Some really tough things I've had to help families through and these are people who planned. I think for that particular situation, that's a fear of a lot of people, and especially people who are very independent and worry about what may happen to them if that occurs. There is the ability within a living will to write in some of that information. And so I think it would be reasonable on your living will to put something very brief that says, in the event of a progressive dementia or loss or permanent loss of decision-making ability, please follow HCPOA recommendations, and then talk to your HCPOA and make sure they know what your issue.
Healthcare power of attorney.
Yes.
Yeah.
Healthcare power of attorney.
So letting that healthcare power of attorney be our voice might be, and then there's also something called the MOST form, right? The medical order scope of treatment. I know that's a physician, that's more of a medical order, but for some people that can be helpful in specifying how aggressive, if they want to go back to the hospital, and some of these decisions that we need to make at times.
Yeah, and that may actually depend on whether this is a young person who fears dementia later,
Right.
or even an early onset dementia, or whether it's somebody who may be having some early signs of dementia or other progressive illnesses that could potentially impact their ability to think and make decisions for themselves. So for patients who have serious illness, maybe they've had a hospitalization, maybe 2 hospitalizations, or know that whatever they have may progress or require them to access a higher level of services like acute care services. I strongly recommend completing a North Carolina MOST form. A North Carolina MOST form is a different discussion than the Living Will form. The North Carolina MOST form is a form that allows a patient and a provider who both have to sign the form. So it is a shared agreement form about how you will be cared for. One, in the event that you have a cardiac or respiratory arrest, which means that you are pulseless and not breathing. So for all intents and purposes, you have died. How we should proceed, because without instructions, even with a living will, okay, without instructions or a clear do not resuscitate form in front, if EMS is called, they will proceed with CPR, which is chest compressions, and attempt to resuscitate you and get your heart and your lungs to start working again, even if that means in an artificial way. So there is that. And then outside of the cardiac or respiratory arrest, there is a choice of treatment interventions that could impact your care in a serious situation. So if you were in a bad state of health that could potentially lead to a cardiac arrest or a respiratory arrest, things like, would you want to be intubated on a breathing machine, which requires a tube and the intensive care unit? Or would you not want to have that and want to have everything but that done? Or if you are at a place where in any situation in which you become unstable medically, would you just want comfort measures only? So there are 3 options really. And so just because somebody has a do not resuscitate order, which means if I am dead, I am not breathing and pulses, please let me be. But if I have a reversible condition, I want that treated aggressively. So that should never prevent you from even having a short-term stent on a breathing machine if there's a reversible condition. Versus, nope, even if they do not put me on a breathing machine under any circumstances, I am not at that point where I believe that is in line with what I would want. Or the comfort care option. And so the MOST form really expands our choices beyond just what's covered in like the living will.
Yeah.
And so if you are someone who has even a slight potential for decompensating or a serious illness, that's why I encourage the MOST form. It also allows you to have a medically informed discussion.
And again, that is for the person with the diagnosis, not the general person in population.
Correct.
Right.
Correct. Yes.
So there is a question about whether there's a standard set of care for palliative care in terms of number of visits and services provided. And I know that is something that we are not yet in North Carolina or in this country to have standard regulation or expectation of palliative care. And it depends setting to setting, program to program, and even who's a part of that team.
Yeah, and just the fact that that question is being asked, I mean, I truly understand that there's lots of variation out there in terms of what is palliative care and what does that mean? What do you get with that? I agree. Sometimes I don't know. But I do know that when you come in to Cone Health and when you're in this hospital, I do know what you will get. And when you're seen in the cancer center, what you will get. However, when we move into the community-based space and home-based space, there are different ways that that care is paid for. And it is highly specific to, as we all know, health insurance companies and also coverage. And there's lots of factors that play into how and why you get services, unfortunately. But that is the way healthcare is now. I would like to think that we do have some standards of care. So we have some organizations like the Center for the Advancement of Palliative Care that has some guidelines and recommendations. They are minimum standards of care when receiving palliative services. And so I do believe that, a good palliative care team would exceed those.
And really asking the organization that's providing the care
Yes.
for clarification and what the expectation is.
Very important to do. And it may honestly depend on many different things. It may depend on what your diagnosis is. It may depend on what your actual needs are. Palliative care is extremely personalized care. And so it should always, at bare minimum, include a care plan where there is an outline of expectations and services that we can and can help with, and who you should call and when you should call. Those are very important to what we do.
So we have one last question, and we are just about at time, but I want to see if we can. So somebody is asking, what kinds of situations should be thought through regarding how we live going forward? For instance, a relative decided to allow a spouse to have surgery with the result of an ostomy bag. The person is now very upset with having this as a part of their life. How can this situation be properly dealt with? And I know there's no quick and easy answer to that, but
so there is one quick and easy answer, and that is that if somebody is confronting a difficult decision in the hospital, they should request a palliative care consultation from their primary attending or their provider or their surgeon immediately. So if there are any difficult decisions like that or question of decisions, I always say it never hurts to ask for a palliative consult. We are a sounding board, but we are also very focused on making sure that any shared decision making is truly grounded not only in the medical recommendation and treatment options, but also taking into consideration what's important to that patient and their loved ones.
Right.
And so that situation probably could have been, prevented if a conversation with the family and the patient, and maybe even, the surgeon, if we were able to facilitate that. I also sometimes think that with some choices, we as healthcare providers do not discuss the outcomes. Patients are willing to go through a lot of suffering and interventions if they think their outcome is going to be good, meaning good for them, which means like back to how I was before I came in. Often when providers talk about outcomes, they're usually talking about things like fixing just the problem, no matter what that means for you. So they fix the problem, or you survive to discharge, that kind of thing. They're not thinking about, well, we can do this, but you're going to have to deal, like with an ostomy bag for possibly the rest of your life. And here's what that's going to feel like and look like. Or you may need a nursing home for the rest of you may need full and total care for the rest of your life. So that's the living part. And we can't make informed decisions about things that are going to happen to us unless we truly have some predictions about outcomes. So I always encourage patients to ask those questions. So if we do this, like, what will it be like for me? How will my living change? How will my life change compared to how it was before? And when we very specifically ask those questions, we can get closer to understanding.
Well, I want to say thank you. This has been a tremendous conversation. I thank all of our participants on the webinar. Everyone will receive email follow-up tomorrow with access to the recording. If you had registered on Zoom, it will have some resources. And then please look towards our next webinar. It's going to be on Thursday, May 9th, and we're going to be talking about how to thrive as a caregiver. So how to manage stress when we are in the position of being a caregiver. And that will be the start of a conversation about caregiving. So please join us for that. Again, Dr. Golding, I want to thank you so much. We know we have National Healthcare Decision Day coming up, which is another good time for us to use as a start to those conversations. And as we close, I just want to share a quote from Ira Byock that says, "I have an advance directive, not because I have a serious illness, but because I have a family." And with that, I will say thank you, and I hope everyone has a good rest of the day.
Thank you. Appreciate being here today.